Okay, so today we're going to be talking about latent TB infection. Kevin, would you like to introduce yourself first?
Sure. Hi, guys. I think most of you know me, and I know most of you, but I am a professor at OHSU in infectious diseases and epidemiology, and I used to be at CDC in the TB division a long time ago. It was a very different place, but I'm happy to be here in Oregon for the last 20 years. We're working with Heidi for a long time and Kylie for a long time. So, and happy to always take your questions on cases, whatever. Just email me or text me. You can always reach out to me.
Thank you. Yep, thank you. I'm Heidi Babe. I'm the TB controller and nurse consultant for the TB program at Oregon Health Authority. I've also been doing TB stuff here in Oregon for a long time, and then prior to that, did infection control for a bit up at OHSU. And was a public health nurse doing communicable disease work with LA County before. And that's where I really learned about TB was LA County, because they have a lot of TB there. Okay, Kylie, I will pass it on to you if you don't mind introducing yourself.
Hey everyone, I'm Kylie Ariel. I'm the TB epidemiologist with Oregon Health Authority, and I've been with the program about 8.5 or 9 years. So compared to Heidi and Kevin, I'm pretty new to this, but I feel like I'm finally starting to get the hang of it.
Okay.
Finally, Kylie, finally.
No.
Okay. All right. So we're going to start out with some epidemiology, and Kylie's going to talk a little bit about TB incidence in Oregon.
Okay, well, these are some slides that I've been putting together. This is the time of year when we finalize our prior year case data for CDC reporting. And so some of this data has been updated like this slide, but some of the other slides are not, haven't been published yet, and they'll be published next week. So Oregon has, and like many places in the country and around the world, Oregon's been seeing an increasing TB incidence starting since about 2020 when the COVID-19 pandemic hit us all. In 2020, we had a sort of artificially, or maybe not artificially, but we had a lower case count than usual that year and an incidence of 1.6 cases per 100,000. And ever since then, we've been having this slow incremental climb up to the 2025 count of 100 cases, which is a rate of 2.3 per 100,000. And just for some context, prior to this, since the early 90s, the peak rate, I don't remember the peak rate in the early 90s, but it was quite considerably higher. And we've been on this long, slow decline since the early 90s until 2020. So this most recent trend is a real turnaround in the what's been happening with TB. And I should also say that there's similar trends being seen nationwide. So this is not unique to Oregon, but we are certainly seeing the effects locally. Next slide, Heidi. We definitely see most TB in the population centers along I-5. This particular slide is not the most current data. This is data that I posted mid 2025. So this does not reflect all 100 cases that we had last year. But it shows the general trend that most TB is seen in the population centers in Washington and Multnomah counties, also in Marion County. And then we get sporadic cases throughout the rest of the state. So even though most TB is in the Willamette Valley area, any county can and does get cases at any time. Next slide. So TB is all about, evaluating TB in Oregon is all about looking at risk factors. And in Oregon, the biggest risk factor for TB disease is a history of having lived outside of the United States. And in 2024, sorry, there's an error in this heading. This is actually 2024 data. In 2024, 73% of our cases came from a history of living outside of the United States. We're not actually able to collect this data anymore. So this is going to be the last, 2024 is the last year that we're going to have this particular data point to evaluate. Because of changes in Oregon sanctuary laws, we're not actually able to ask people anymore whether they lived outside of the US or not. We do have a couple of proxy questions that sort of get at this question, but this is the last time for a while, I think, that we're going to see this firm of data on this particular risk factor. The reason that the risk is that having lived outside of the US is the biggest risk factor is that TB is still so endemic in many, many places in the US that when people come into the US, they often bring a TB infection with them. Next slide. So TB's, like many of the diseases that we track in public health, TB is a disease that reflects the social determinants of health. In Oregon, people who are native, US born and non-Hispanic white have a pretty low incidence of TB at less than 1 case per 100,000 people. That's that yellow bar near the bottom, the really small one. And pretty much every other race and ethnicity group has a much higher incidence of TB. For quite a few years, the highest incidence groups have been among the non-Hispanic, Native Hawaiian, and Pacific Islander groups. These are primarily people who come from the Marshall Islands and Micronesia. One of those countries have a very, very high endemic incidence of TB. And one of the reasons that we see a high incidence among that group in Oregon is because we have quite a robust Micronesian and Marshallese community in Oregon, and they are able to travel to and from their countries without any visa restrictions. So we have quite a fluid population of Native Hawaiian and Pacific Islanders that live in Oregon, and these people come and go very freely, and they're back home. There's so much TB that they often bring it back here with them. We've been working quite actively with Marion County over the last few years to really engage that community. And we are seeing those rates in the Pacific Islander communities drop a little bit. So that's good news for us. Next slide, Heidi. Other risk factors for TB, one of the biggest is people who smoke tobacco. We see some people who are healthcare workers that may have been exposed in the course of work, but it's a little hard to drill really carefully down into those data to see whether those exposures happened, because they could be very historic infections, but we have no recent evidence to point to any significant transmission in healthcare facilities, so we're not terribly concerned about that. Diabetes is another risk factor for TB disease, as is previous treatment for latent TB infection and unstable housing or homelessness. Next slide. This is an array of some less common risk factors, but they are all risk factors that we track and look at in our cases in Oregon. Next slide. So I just want to touch on some concerning trends on TB in Oregon. And one of those, obviously, is our rising incidence. We're not really sure what the cause of that is at this point. It is comforting, I guess, in some way that this is happening all over the US. So it's certainly not a trend just in Oregon. We do have those vulnerable communities that I mentioned earlier, particularly the Pacific Islander community and Chukis and Marshallese. They have a 10-year average rate that is more than twice as high as any other community, and their 5-year rate is even higher, which mostly reflects some ongoing outbreaks that we've been having in those communities. Co-infection with HIV is always something that we keep an eye on. We usually have about 1 co-infected case per year. But in Oregon, at least, it's unusual for that co-infected case to have AIDS disease. So usually the HIV and the TB are diagnosed around the same time, and they're both able to be treated. Next slide, Heidi. Another concerning trend that we've been keeping an eye on and have to do some more work to try to dive down into is that the death rate among our TB patients has increased since COVID-19 started in 2020. This chart it's up to 2024 data. This chart shows deaths among people with TB that were actually attributed to TB within 1 year of diagnosis. So sometimes people with TB disease pass away for other reasons that aren't related specifically to their TB, but these are strictly TB associated deaths. And you can see that we had a peak of about 10% of cases in 2021 dying within a year of diagnosis related to their TB disease. There were a lot of things going on in hospitals and healthcare, as well as people's ability or willingness to engage with public health that might inform that increase in death rate. And also, the average age of TB cases has increased, and we've been having more cases who are older post-COVID than before. So some of those factors might be related to this increase in death rate. And we are still working on publishing the 2025 data. So hopefully that 2025 bar will even be lower than 2024. And there's one more concerning trend that I don't have a slide for, but there's also been a real increase in people with TB and facing unstable housing at the same time, unstable housing and homelessness. So that's another factor that our program is working really hard to address particularly by providing supportive services and housing to people while they're on TB treatment. Heidi, do you have anything to add? Dr. Winthrop?
No, I think that's really nice to see this update, Kylie. Makes me think we should do this every year. I agree with everything you said. I don't know why we have more deaths either, other than some of the facts you point out. Maybe some of these folks are just older and sicker to begin with. But can I ask a question now? Why can't we collect the info on birth overseas or living overseas? What was the rule there again?
So that's related to Oregon sanctuary laws. And basically, I'm not an expert on this, but basically the essence is that any public entity in Oregon, and the Oregon Health Authority falls under that, all DHS services fall under that, local public health also falls under that. We can't ask questions about where a person is born or their immigration status. And that's related to primarily to equity issues and to protecting people from forces that we can't necessarily control. So in early 2025, we got the notice from the Department of Justice that we cannot collect that data point anymore.
So that's a state thing.
It's based on state law that was it's a sanctuary law. It's been in place for quite some time, but we were a little bit slow to realizing that these kinds of questions asked in public health aren't allowable under sanctuary law. And it's not just TB, but TB is the disease that relies most on that risk factor of being born overseas. So it's a real causing a gap in our understanding of who our cases are. We do have one proxy question that we can ask, and that is a data point that's required by CDC and has been deemed okay by the Department of Justice. And that question is whether a person with TB has lived outside of the US for 2 or more months consecutively. So that would capture anybody who immigrated to the United States at 2 months of age or older. And it also captures people who are US born and may have lived overseas for an extended period of time.
Well, that's good. Yeah, I was going to ask you that because you presented the data on lived overseas. So I wonder what the definition of that was at. So it's 2 months consecutively.
Exactly. So if they lived overseas or outside of the US for 6 weeks, that doesn't count. Or if they lived
Yeah.
outside of the US for 6 weeks and then came back for a month and then went overseas again, also
Yeah.
that wouldn't be
Doesn't
captured.
count. Yeah.
But
Um,
it's the closest that we have at this point.
We
Cool.
do have a question in the chat if that specific data with birth country applies to the LTBI screening questionnaire that we provide. And I will say, I do believe that it does. And to my knowledge, most of our current or all of our current documents on our website, including that screening questionnaire, should have had that that question removed
Right.
or altered. So if it's still on the form that you're currently using, you may want to double check that you have the current form.
Now, just another word about that. I don't want to take too much time up with this, but local public health straddles this line between healthcare and government, right? So you might want to consult with your legal counsel at your local public health level about using this this piece of information, because it still is relevant to healthcare and to the risks that your patients and your clients experience. But we as a state entity cannot report it anymore. So we can't ask that from you and we cannot report it.
Debbie in the chat wants to know if this is also true for hospital entities. Do either Heidi or you have any?
I think you have to talk to your legal counsel. Can't speak to it outside of public health.
Yeah, I would just say clinically as a doctor, I mean, I don't care about any of this. You have to ask your patient where they're from. So you may not, the state may not be able to record it or report it, and that's the law, as Kylie was talking about. But like you as a clinician or a nurse, or if you're working the patient up, you need to ask those questions. And I mean, you can't do a TB skin test and interpret the result without knowing where the patient's from. So that's different than reporting. It's a different issue. So obviously, anybody's healthcare information is protected by law, and it's HIPAA. We have HIPAA. I mean, all those things, those are all confidential and kept confidential. So it's just that's a different issue. So.
Oh, there you go. Your
Oh, and
dashboard.
this is a link to our TB data dashboards. And right now they are showing 2024 data, but hopefully if I stay on track by next week, they'll be updated with the 2025 data.
How often is the dashboard updated, Kylie?
At least once a year in time for World TB Day. Sometimes twice a year.
Nice. I'm checking it out right now. It's cool. That's great.
Thanks, Kevin.
All right, thank you, Kylie, for the update. And just a reminder, she was talking about TB disease cases, and our webinar is going to be about latent TB infection today. So every time we treat somebody with latent TB infection, of course, we might have one less case of TB disease. So here's a list of the acronyms we're going to use today because there are a lot of acronyms in TB. I put together this acronym list. And we will send out the PowerPoints later so you all have them if needed. So first of all, it's important to realize there's a difference between latent TB infection and TB disease. So this is just a real simple breakdown. Today we're talking about latent TB infection. Basically, the IGRA or TB skin test is positive. The patient feels well. The chest x-ray is typically normal. They're not infectious, and treatment for latent TB infection should be considered. So TB disease, we're talking about somebody who is actually sick. They might have symptoms like a fever, chronic cough, chest pain, weight loss, eventually coughing up blood, and fatigue. Usually the chest x-ray is abnormal, but it could be normal actually if the person is immunosuppressed or if they have extrapulmonary TB disease or TB disease outside of the lungs. And you will find that the labs are positive, the sputum is positive for TB. These are the folks that are infectious. And we treat TB disease by having the patient take 3 to 4 drugs for at least 6 months, typically speaking. Okay, so rolling along on latent TB infection, who should we test? We really only want to test people at high risk for TB. So those people who are recently infected or clinically have a condition which could increase the risk of progressing to TB disease. In general, we don't want to test the general population, and I think we are pretty good about not doing that these days. All right, so Kylie already talked about some of the risk factors, but of course the number one is close contact to a person with TB disease. People are also at high risk who frequently travel or were born in countries where TB disease is very common. And there's a list of those countries there. Canada, Australia, New Zealand, and Western Europe or Northern Europe are generally not considered to be high risk settings. Also, residents or employees of congregate settings, although I do have to say that in Oregon, we don't have a ton of cases from congregate settings like jails or healthcare facilities. And then infants, children, and adolescents exposed to adults who are at increased risk.
And just a comment, I mean, on the list of countries, I mean, other countries is listed there, but I mean, certainly the South Pacific is big for us in Oregon. Federated States of Micronesia, Chuuk. I mean, we see a lot of cases from there, and even Mongolia. For being Greater China, Mongolia, and even some of Eastern Europe. Ukraine, for example. So those are things that come to mind in Oregon specifically.
Very true. All right, and these are risk factors for developing disease after somebody has been exposed.
Yeah, my only comment here is, of course, some are stronger risk factors than others. And as Kylie said, we don't have a lot of HIV co-infection here. I mean, I think you mentioned one case a year, which was good to see because it wasn't like that a long time ago. So, that has become much less of a risk factor. But certainly some of these are, fairly immunosuppressive conditions, particularly malignancies and some of the drugs used, the TNF blockers, for example. They're pretty strong risk factors. So, and for some reason, we always have a handful of dialysis center cases every year that trigger contact investigations and whatnot. So renal failure definitely is, maybe a stronger risk factor than some of the others there. So.
Okay, diagnosing latent TB infection. So, Kevin, do you want to roll through this bit here?
Yeah, and you guys probably know all this. So these are tests that don't tell you if someone's infected, right? They tell you if someone's immune system remembers seeing this bug before. That's how I explain it to the patients. So, I mean, you can tell there's a lot of problems with that right up front. We don't actually know who's infected, and they both basically accomplish the same thing. Again, they're testing your lymphocytes to see if they've been exposed to TB before. And then if they have, that they remember it and they get activated, they get excited, and they dump inflammatory mediators. If it's skin tests, you get a bump on your skin. If it's a blood test, an IGRA, then you can measure the amount interferon gamma. So kind of the pearls are, it takes 2 to 10 weeks for you to build a response either way if you're exposed. So this is a cell-mediated response, and it takes 2 to 10 weeks before you'd be positive. So this is kind of why we like to, if you can, you test someone right after exposure to kind of get their baseline, and then you wait, 8 to 10 weeks and test them again. That's the two-step or second test. LTBI, we used to say a third of the world was infected. That was because of a lot of false positive skin tests. Now we're kind of down to saying 20 or 25% are infected, based on probably more specific IGRA data. But suffice to say, it's pretty common, and it is, much more common in some countries than others, which is why you really need to know where your patient's from. 5 or 10% of people who are exposed develop active TB. So I always tell people, like, TB is actually a pretty good vaccine, and if you can contain it, you're probably protected from getting infected again. But the only problem is for 10% of people, they can't contain it, and their immune boost from it obviously fails, and they develop TB. Now, most of that's in the first 2 years after infection, but Well, 50% of it, we always say, but it's probably more common in the first 2 years, but then the rest of the risk is throughout that person's life. So we're going to go through some of the sensitivity, specificity issues, and placement issues with some of these tests, and I'm sure Heidi will be glad to talk about placing a skin test.
Yeah. Okay, so a TB skin test. I don't know how many people still use the TB skin test, but it certainly can be error prone. It's easy to read incorrectly. Here's a little slide demonstrating how it should be read. Okay, so just a reminder, if somebody has a prior positive TB skin test or IGRA in a healthcare setting or other setting, really you just need a document of that positive test result in a negative chest X-ray, and they're cleared to work. You don't need to repeat that TB skin test, the IGRA chest X-ray, just screen them for signs and symptoms of TB. So a couple of exceptions to that. Say you want to treat the person for LTBI and they only had a TB skin test way back in the day. Maybe you want to get an IGRA just to confirm, and everybody would need a new chest X-ray before they start treatment. Another time to rescreen somebody is if they have symptoms of TB disease, even if they were treated for LTBI in the past. You want to get a chest X-ray and possibly sputum. Okay, administering the TST. Here's how you do it. Basically, it's an intradermal injection, which can be a little bit tricky to do, but once you're used to it, it's not too bad. Don't drop the solution more than a half hour prior. So sometimes when we're doing big contact investigations or you're testing a lot of people, you might be tempted to draw it up prior, but don't do that. You don't want to put it on any kind of scar or anything like that. Most importantly is you want to produce a wheal that's at least 5 millimeters to the best of your ability. And I have to say, I've done many, many TSTs in the past, back when we didn't have the IGRAs, and some people I think are impossible to get a wheal on. I don't know, especially people who are elderly. What do you think, Kevin?
Yeah, no, it's really true. Yeah, so
Yep. So that's why IGRA is good for certain people. So what if you screw it up? It definitely happens. If you don't get a good wheel or the, fluid leaks out, go ahead and repeat it. And put it on the opposite arm and make sure that you document it, and just be aware you might end up with two positive results, one on each arm. That's happened to me before, but it is okay. Okay, so reading the TB skin test can be a little bit challenging. So you want to read it 48 to 72 hours after it's placed, but if it's positive, you can read it up to 7 days later. The patient can't read it themselves. Even if that patient happens to be a healthcare worker, you should have somebody else read it. What you want to do is you measure it across the arm, that is the transverse. Every once in a while, we'll get somebody who's reading TB skin tests the other direction, but really you want to measure it transverse. You record in millimeters, even if it's negative. So you could say have like a 1 millimeter negative result. You measure the induration or the bump and not the erythema or redness when you measure a TB skin test. So sometimes it's helpful to use a pen to mark the margins. You can kind of hold it up and look and see if you see anything. Always use your fingertips to feel the surface. And if you're still not sure what you're seeing or if it's a positive, you could look again the next day, or you could repeat the TB skin test, or you could just get an IGRA. Again, that's right and wrong reading. So one of the unfortunate things about the TB skin test is we have this problem with people not coming back for the read. Again, they should come back in 48 to 72 hours, but if they're a little early or a little late, it's okay. And if it's positive, can read it within 7 days. If there's no reaction and it's been greater than 72 hours, you would need to repeat it if they don't show up. If a new TB skin test is needed, go ahead and place it on the opposite arm. Okay, so for those of you who work in healthcare, I get this question a lot. Do we need to do a two-step TB skin test? And the answer is yes. So this is the algorithm for doing a two-step TB skin test. I'm not going to roll through it because, again, a lot of people have switched to IGRAs, but you will have it in the slide set if you need it, or you can ask questions later in chat. Okay, positivity criteria. So you have to look at the patient's characteristics to determine when a TB skin test is positive. So this kind of outlines that. I think the most important thing is recent contacts to TB, 5 millimeters and greater is considered a positive result, along with these other folks. And then we have people who are 10 millimeters and higher, which is most people. And finally, 15 millimeters and higher. And in general, these are people that don't have any risk factors for TB. So again, we don't really want to test people who don't have risk factors. I do know that like Peace Corps or some other places maybe require it, but in general, if someone that hasn't had a risk factor, we don't want to test them. Okay, so just question for you to think about. In your clinical setting, do you ask questions to determine your risk factors for TB and also immunocompromised status? Kevin and I both recommend this gets done if you use TB skin tests or IGRAs, right, Kevin?
Yeah, either one. I mean, it's really hard to interpret the test. Obviously, helps you understand the positive predictive value of the test as well as the negative predictive value of the test. So, and I always say, based on the a priori probability, I mean, you should have a good sense of what the patient's results should be. And if you don't get that result, you should think about repeating the test. That's kind of my general rule of thumb.
So a problem with the TB skin test is we can get false negative results. I think one of the most worrisome is if the person has overwhelming TB disease, sometimes we get falsely negative TB skin tests. And of course, that's a problem. So you don't use a TB skin test to diagnose TB disease, basically, is the gist of it. And then these other issues can also cause false negatives.
Yeah, and it's a good point about TB. Active TB, about 20% of people with active TB will have a negative IGRA or a skin test. More likely negative skin test. IGRAs are more sensitive, but still you can get negatives, and that often causes people to make diagnostic errors because they think, oh, the person doesn't have TB. So
Yeah. All right. Of course, if you don't place the TB skin test right, you could get a false negative, or if the tuberculin's not stored correctly. We also, with the TB skin test, get false positive results. So that's why, again, IGRA tends to be preferred. If the person has a non-tuberculosis mycobacterium like M. avium, you might get a false positive TB skin test. The IGRAs, no, they won't be falsely positive because of that. Same with BCG vaccination. You could get a false positive TST, but the IGRAs, again, will not be positive because of BCG vaccine.
yeah, and I should say too, there are new skin tests out. Heidi and I have talked about this before, and they do employ the same antigens that are in IGRAs, so ESAT6, CFP10, 7.7, and these are highly specific for TB. So there is a new generation of skin tests that gets around this BCG false positive issue, and they're much more specific. Unfortunately, we don't have access to them in the U.S. as far as I'm aware, unless you know, Heidi. But they're in Europe and elsewhere, but I don't think they're here. But
I haven't seen anything about it yet. Yeah.
yeah.
Hopefully soon. Okay. So with the TB skin test, the way you document it is pretty specific, and here it is all outlined for you. Again, recorded millimeters, and then record if positive or negative based on the patient's characteristics. And give the patient a copy of their results, especially if it's positive. Tell them to not lose it because their TB skin test will likely always be positive. All right, here's a little question for y'all to think through. Patient comes back for his reading on the TB skin test. He tells you he was moving this weekend and had to carry some boxes, and it messed up his TB skin test. You look at his arm and it looks something like this. And this is a kind of a real life example I encountered once where a patient was telling me like, well, I just messed it up and that's why. So thoughts about what you might do if this was your patient? What do you think positive, or how would you go about dealing with this? Unfortunately, I can't see chat, so I don't know if anybody wants to put what they would do in chat, but
Yeah, this is the UPS guy. Was this the UPS guy?
sure, yeah.
Repeat, consider positive.
Yep. I think right. Yep, you could repeat it. You could consider it a positive. You could tell he already doesn't believe the results, so maybe you could offer them an IGRA and see if that convinces them. So yeah, good options there. Okay, when do we use an IGRA or a TB skin test? IGRAs in general are preferred. It's just a better test. So IGRAs are preferred, especially if somebody's BCG vaccinated. If you're doing healthcare worker screening, it's preferred. And definitely if you're doing a contact investigation, we usually recommend IGRAs as well. A TB skin test really mostly for kids under the age of 2, although sometimes we see clinicians use it for even younger children, use IGRAs for even younger children than that. And you might use both of them if the result is really critical because the person's immunocompromised or the interpretation of the TB skin test or IGRA are unclear.
Yeah, it's not a bad idea to use both, and also just young kids, under age 5, if you're really worried. It should increase your sensitivity by using both. So.
Okay, so we're going to talk a little bit about IGRAs here. So we have 2 types, quantiferin and T-spot, and like I mentioned before, the results aren't affected by BCG or most non-tuberculosis mycobacterium. T-spot, it's a blood draw with 1 tube only, and there's no issue with time to the lab. Results are pretty simple and easy. They're either positive, negative, or borderline. And I believe T-spot now is only available through Quest Diagnostics, as far as I know. Do you want to talk about quantiferin plus?
Sure, I'd be happy to. This was a test kit that actually my program here, I mean, we did the pivotal sensitivity and specificity studies along with a couple other groups for their FDA package. So we got intimate knowledge of their sensitivity and specificity. And so the way this test works and what was new about it, why it's a plus, is there's another tube. It was plus 1 tube. So that 4th tube there, the TB2 tube, the one on the bottom, was a new tube, and it looked at not just the usual CD4 lymphocyte responses, but it also looks at CD8 responses, not just to those antigens that I'd mentioned before, but also to some proprietary TB peptide that I don't know what it is. Nobody knows what it is, but it's some peptide that was isolated from TB that elicits immune response. It's in that tube. So TB1 is kind of like the old test. It's just the CD4 responses and looking at interferon gamma production in the presence of the antigens. TB2 is that plus the CD8 response. The idea was that CD8 response was probably more likely to be seen in active TB. So maybe this test would be more sensitive, particularly in active TB, or help pick up people that are kind of early in transitioning from latent to active. And there's some data that supports that idea. I think more than anything, though, probably having the 2 tubes makes it a more specific test in that, you kind of have a 2-for-1 deal. You have 2 tests, and they're both independent tests, basically. And so if they're both positive, it's really hard for me to blow it off. I mean, it makes me think it's probably real positive. If just one is positive, definitely it is still ruled a positive. I mean, that's how the test is. Either one being positive is a positive test. But again, if just one's positive and the person has no risk factors, I'm not sure it's a real positive. I might repeat it. But if both are positive, it makes me feel more likely that it's a true positive. So that's kind of my 2 cents on that. The nil tube there is just your baseline interferon gamma production. So you measure it in the antigen tubes, and you minus the nil, whatever the background is. So that tells you how much is being produced by the lymphocytes when they're stimulated. And the mitogen is like a nuclear bomb. Everybody should react to that. Everybody's lymphocytes should react to the mitogen. If the mitogen tube is not reactive or zero, then there's either something wrong with the tube, the test, or the person, the patient. So, we use that mitogen as a positive control. It should react. So if it doesn't react, then the test is going to be indeterminate. You're going to have to repeat it. The shaking thing's funny. I was just at a conference in North Carolina Saturday talking about this. I mean, when we first were helping develop this test, I was at CDC, and we were working with Celestis, who was the maker before QIAGEN bought them a few years ago. But I mean, this was an issue. I mean, we figured out in the context of a couple outbreaks and CIs that people were overshaking the tubes, and if you overshake them, you were getting more indeterminates and probably false positives. And if you didn't shake them enough, it was affecting the sensitivity of the tube. You weren't finding positives. So after a lot of trial and error, someone came up with the 10 shake method. Seems to be like the optimal number of times to shake the tube. Not to destroy your faith in science, but I mean, who knows? I mean, it was a very comical experience, but in the end, probably about 8 to 10 shakes seemed reasonable. It wasn't causing this indeterminate problem unless you really shook more than that. So that's the story there. Not many people know that story, but anyway, that's what we do. You got to shake it right. So I mean, even now, I see results sometimes that makes me wonder if people are overshaking or undershaking. But you get a positive, negative, or you get the indeterminate, like I mentioned, particularly if the mitogen doesn't react, it'll be indeterminate. The quantitative results, it's got to be above 0.35, meaning the amount of interferon gamma produced after incubation with the antigens has to exceed the background greater than 0.35. So, test results that are near the cut point are more likely to be false positives. The farther away they are from that cut point, the more likely they'll be real. So, sometimes we repeat things if they're right on the cusp of the positivity range.
We have a question in the chat in regards to the iGrad and the tubes. Does it matter what order that those are drawn in?
No, I don't think so. Good question, though. And then this thing just got published like a week ago, so I just put it in here. But it was just a meta-analysis. You don't even need to know this, but you can see in the results here, there's a bunch of capitalized. These are new IGRAs, standard E, the liaison, the echroma, the vitus. In fact, we did the pivotal studies for the vitus TB IGRA. They just finished. I don't know the results yet. Wantai. Anyway, there's a whole slew of new IGRAs coming. So I'm just prepping you for this talk in about 3 years when we give it. We're going to probably have to be talking about some of these. Some of these won't come to the US. Some of them are in China. Some of them are in Europe. But I know the Vitus is probably going to be here. The Roche has a platform. We just finished helping them with their study. Same deal. I mean, a lot of these tests, the goal is to, like most of our society these days, is to eliminate humans from having to do anything. So these are mostly like automated tests, and they're not necessarily improving on the antigen set or the specificity. Yeah, nothing of that. It's just like, how can we do this in more automated fashion without people? So that's what a lot of these platforms are. And I can tell you, like the Vitus, I mean, their initial tests showed, terrible specificity and off the charts sensitivity. It was a big problem. The test was rigged up to be way too sensitive. And that's been some of the issues with some of these others as they've undergone development. So a lot of these tests are being refined and then retested, and they're trying to show that they can be equivalent to the T-spot or the QFT plus. So those are usually the gold standards. And in fact, this systematic review, if you're interested, I mean, they use the QFT plus as the gold standard. So, most of these tests were stacking up fairly close to the QFT plus, but really only 2 looked really close. So anyway, this is a moving target, something to just keep your eye on. In a few years, it'll probably affect your life here in the US.
More confusion possibly.
Yeah, that's it.
Okay, like we said, there can be false positive IGRAs or TB skin tests. So you want to do a risk assessment for everybody so you can know what their risk factors are. And then if you're ever skeptical of the result, go ahead and repeat the test. We do know that people flip back and forth from positive and negative on the IGRAs, as shown by healthcare worker testing. So when in doubt, repeat. Okay, so we're going to talk about some special populations and testing. So this is just a little case study. You have a new patient who was born in Thailand and they arrived in the US about 10 years ago. She was diagnosed with rheumatoid arthritis and she'd been on prednisone. You want to switch her to Humira. How would you test this patient for LTBI, Kevin?
I'd just treat her. I'm just kidding. Yeah, I mean, you definitely want to use an IGRA. I mean, she's pretty immunosuppressive. She's on prednisone and she's got RA. Both of those factors cause false negative results. They lead to anergy. So I would, I'd think about testing with an IGRA. I might even do a skin test followed by an IGRA, a few days later. That would help bring out a positive IGRA if there is a true positive response. So that could increase your sensitivity, that kind of strategy. Probably most likely she's coming to your clinic, you're just going to do an IGRA. But if it's positive, great. But if it's negative, you'd really have to think about it. And you'd want to repeat it probably given where she's from and the fact she's immunosuppressed. If she wasn't on prednisone, RA wasn't, raging, she was pretty immunocompetent, you're going to be much more likely to accept a negative result. So some of these cases can be kind of complicated, not straightforward. You got to think about, how immunosuppressed they are. Should they be positive? What are the risk factors? Things like that. But that's how I start testing. I'd probably just do an IGRA and a chest x-ray. All these people should have chest x-rays anyway, because you certainly want to rule out active TB before you put them on Humira. So those would be the things to consider.
Use forwarding. Okay. These are some classes of this type of drug. Is there anything you would like to add, Kevin?
No, other than it's not just TNF blockers. There's other drug classes like JAK inhibitors, probably IL-6 blockers. They all carry probably similar risk. And then there's a whole slew of other biologics that you've heard me talk about before that are probably, there is some risk, but not as much risk as these agents. I mean, TNF blockers are probably the riskiest to be fair. So, but you will see people being screened before using a variety of other agents as well.
Okay. So I think we kind of talked through this already, but
Yeah.
yeah, I don't know if there's much to add. Do you still recommend starting LTBI treatment before?
Yeah, someone was asking me that this weekend. So, I mean, you don't really have to wait more than a day. I mean, there was this dogma to wait for a month. It was based on a study a long time ago. It was just a observational study. It's just only everyone waited a month because that's what they decided to do just out of the blue. All you need to do, and this is based on CDC old guidelines as well as just data from randomized controlled trials. A lot of trials we started just testing people at screening, and if they tested positive, we'd let them into the trial as soon as they started their LTBI therapy, and then they could go on their TNF blockers. So you really just need to make sure they've started their TB prophylaxis before they start their TNF blocker or other drugs. So I usually tell people wait a few days or a week, just functional wait, so that they actually picked up their rifampin and they actually started it before you go ahead and infuse them with infliximab. So, but that's kind of the deal. It just has to start before.
Okay, so going on to TB case contacts. To figure out who's a contact can be a little bit tricky, but these are the different things you want to take a look at. You test contacts right after the exposure, and I think we talked about this a little bit. And again, 8 to 10 weeks later, an IGRA is really preferred, but a TB skin test is acceptable. And in general, you want to try to stay with the same testing method. So, but it's not, critical. So just got this question. Someone said, well, our first test was with the TB skin test. Is it okay if we do the second test with an IGRA? And I would say yes, because an IGRA is preferred. So that would be just fine. All right, so contacts that are less than 5 years old and window prophylaxis. This one's when things get really hard. Again, little kiddos are at high risk for progression to disease. So what you want to do is a TB skin test and or an IGRA, depending, and then get a PA lateral chest x-ray and medical evaluation regardless of the TB skin test or IGRA. And in the medical evaluation, what you're really looking for is a scrofula or swollen lymph nodes or failure to thrive, cough, symptoms like that, fever. If the chest x-ray and medical evaluation are normal, then you start LTBI treatment using INH or rifampin. Most of the time, people are using rifampin now for window prophylaxis. And then you go ahead and retest them in 8 to 10 weeks. So you would at that point stop the window prophy if at the retest the child is negative and they're older than 6 months old. If they're younger than 6 months old, both the TB skin test and IGRA don't function very well. So a lot of medical providers will go ahead and complete the course of rifampin just to be on the safe side. So there you go. Again, we might have contacts with a previous positive TB skin test or an IGRA. It must be documented. If it's not, then you want to redo it. If they never completed treatment, now would be a great time to offer it again. And of course, get a new chest x-ray if you're going to treat. If they were treated previously, you really only need to do a symptom check unless that person is immunocompromised. All right, so another question for you all to think through. You're referred a TB contact. She lives with the index case. She had a document of a positive TB skin test, normal chest x-ray, and completion of treatment with 9 months of INH. Pick one, and you can put your answer in chat or just think about it to yourself. Which would you do?
Heidi, there's a question in chat asking to explain what window prophy means.
Oh, sure. Yeah, so this is window prophy. It's basically treating a child or somebody who's highly immunocompromised with rifampin or isoniazid in that 8 to 10 week window period. Kevin, is there anything you want to add to that?
No, it's just that it's window because that period is called a window. That's all. Yeah.
Yeah, exactly. I don't know why it's called a window, but I
I
guess
think it's the
we're
window between contact and deciding if someone's really positive or not. I don't know, I guess.
Yeah, yep.
It's a window of opportunity, Heidi.
Yeah, right. Exactly. All right, so okay, so back to our little case here. Let's see, what would you do? They had a positive TB skin test in the past, normal chest x-ray, and their contact, they completed 9 months of INH in 2001. So the answer, I think, and Kevin, you can tell me if you agree, would be 3. Start by assessing for TB symptoms. If they're not symptomatic, there's probably nothing else you really need to do at this point.
Yeah, no, I agree. I think if they're immune suppressed, like you said in the prior slide, I'd probably do a chest x-ray. But if they weren't, you don't have to do anything else. The other thing I should say too, the question I got last weekend, and I get this frequently, is someone who has a history of being positive, they get screened because they're going on a TNF blocker, for example, and they're negative, and then everyone says, "Oh, that's fine, they're negative." Just just remember, like, having a history of a test and that result is really, really important. So, as I explained to this woman, a lot of people go negative, they get allergic, and so even if they've been treated for LTBI before, they should stay positive. Now, we know 50% of people who get treated will end up negative on their subsequent testing, but it's really just because they're allergic. I mean, they should, you've cleared antigen out. They've gotten allergic, but they should still be positive. If they're still like I said, 50% would be positive still, and you expect to be positive your whole life. That's why we don't repeat tests on people, because we expect them to be positive. But if it goes negative, it just means they're allergic. So it
Okay.
doesn't correlate with the success of treatment. I think that's the key, and a lot of people think that. So
Yeah, totally right. There's no test of cure basically for latent TB
yeah,
infection.
exactly.
Yep. Okay, treating LTBI. So a lot of patients are going to ask, what is my risk? And it really depends on when they were exposed and their immune status. We really are most concerned about people who are just exposed. Your highest risk is the first 2 years after your exposure. Also, there's kind of this neat online TST IGRA interpreter where you can put in the patient characteristics and it'll kind of come up with a risk for developing TB disease. So in general, most people probably who have LTBI are not going to break down with TB disease, and that's sort of a fact. But of course, we still want them to be treated. Okay, again, you need to rule out TB disease before you start LTBI treatment. Check for symptoms. For adults, just a PA chest x-ray is typically needed. For little kids, a PA and lateral is important. And then we want to make sure it's a pretty current chest x-ray, because if the person has TB disease and you start them, say, on only rifampin, they can develop drug resistance and their TB disease will be hard to treat. So we want to definitely make sure that they don't have any TB disease in their lungs. So before you start treatment, it's a good idea to get a physical evaluation, especially for kids, and get any info about previous treatment for LTBI or TB disease, and do an assessment for liver disease, regular use of alcohol or drugs, HIV, pregnancy, or if they are immediate postpartum. If there's any risks, go ahead and get LFTs or CMP before you start treatment. Kevin, do you get LFTs for every patient before they start LTBI treatment, or just if they have risks?
Oh, I do. I mean, we live in a world where you ought to just get them. That's what I think. People are on enough other hepatotoxic drugs. They're so common these days. They drink. I mean, it's just technically you don't have to in a young, healthy person who doesn't have risk factors. But most of my patients are on a statin, or they're on something else that also is hepatotoxic. So it's just good to have at least a baseline, I think. And I mean, there's also people with hepatitis B and C and things that are out there. So I think it's wise to test everyone at baseline. Whether you repeat it or not is another question. You only need to repeat it if they have baseline abnormalities or they have risk factors for hepatotoxicity beyond their drugs. You probably don't need to repeat it. But that's why it's important to get a baseline, just so you know if you need to follow it closely or not.
Thank you. Okay, treating LTBI or not, there isn't an age cutoff anymore. So you just kind of look at the risk of disease progression versus treatment toxicity. All right, so LTBI treatment and some more complex people to treat. So LTBI treatment in kids, we really recommend that kids with LTBI get treated because they have a high lifetime risk of progressing to disease. And also, especially young kids, they can develop TB meningitis if they develop TB disease, which is very dangerous for them. For kids, we really recommend rifampin daily for 4 months, or INH and rifampin daily for 3 months. And those two regimens are fine for any age. 3-HP, which we'll talk about later, is okay for kids 2 and older with directly observed therapy, we usually say. And then finally, isoniazid daily for 9 months is an alternative, but not too many people are using that anymore. Treatment for kids is weight-based, and there's some tables available that you can use that will kind of show you how to dose it. Liver toxicity is rare, and in general, we say avoid the SERPs, but some people use them and the kids do fine on them. Okay, and if the child's taking rifampin, they definitely don't need B6, but if they're on isoniazid, B6 is really only needed if the person is being exclusively breastfed or they're malnourished. Okay, another question. A pediatrician calls you, they're caring for a 1-year-old TB skin test positive boy from Mexico. The PA and lateral chest x-ray is normal. What's your recommendation? You can go ahead and put that in chat or just think to yourself which one you would do. And then I'm going to put Kevin on the spot. Which would you do?
Well, you guys hopefully have had enough time to digest and think about it. So I mean, first you're trying to classify this kid, and if they're healthy and they have a normal X-ray, they don't have signs of illness, then you're going to say they have latent TB. You may also be tempted to say, well, boy, that skin test is probably positive because he had BCG, 8 months ago. You could think about doing an IGRA to sort that out. Of course, it's hard to know in kids under 2. The tests aren't that sensitive. So this is a situation where I would probably do an IGRA. If it was positive, then I have like really good weight to say, hey, let's treat this kid. If it's negative, I kind of don't know. I think I talk about, pros and cons of treatment as a parent. Now, RIF's pretty well tolerated, particularly by 1-year-olds. So, I mean, it's only, a 4-month therapy or even 3 months with, rifapentine and INH. So, treating it now is just so much easier than it was a few years ago. So, I mean, the bar to convincing this kid or kid's parents to accept treatment's a lot lower. So I mean, those are the things I think about. I mean, in the end, if I wasn't sure it was a true positive, I think it's a conversation with the parents and it's quote unquote shared decision making, and probably up to them. I mean, it is up to them. So, but you have really good safe options here. Short course for rifampin-based therapy. So, erring on the side of being conservative might be the thing to do. I don't think you need to test the boys' parents. They're probably positive. They're from Mexico. So, and that's just kind of a separate issue. So,
Thanks. Perfect. Okay, LTBI treatment during pregnancy, the guidelines or the recommendation is kind of changed. Some clinicians think still you should stop LTBI treatment or not treat LTBI during pregnancy unless the person's a contact or HIV positive. The recommendation would be to defer until 3 months postpartum, but other clinicians now say it's okay to treat using rifampin for 4 months daily regardless. What do you think, Kevin?
yeah, I mean, I think you don't probably necessarily have to worry about this, but I mean, I'm pretty ginger about giving anyone who's pregnant anything. So because even though they may not cause a problem, if there's a problem that happens, then everyone's going to blame whatever you're giving them. So I tend to wait, and it's not just with INH, but I even wait with rifampin. But unless they're a new contact, I think then probably the benefits outweigh the risk. I would definitely go ahead and treat them. So,
Thanks.
and also if they're immunosuppressed, I mean, it's different. If they have some immunosuppressive condition, that might push you as well to treating.
And even if you're not treating the LTBI, would you recommend that they get a chest x-ray before the baby's born?
I would, yeah, absolutely. Chest X-rays have like almost no radiation in them now. It's kind of like your dental X-ray.
Not too dangerous.
Yeah.
Okay, so treating older people, because I'm a little older myself, I like to think older people are people in their 70s and above. Um,
Jeez, Heidi. I mean, you're not that old.
I know I'm not that old at all. Anyways, so we generally would treat older people with rifampin unless maybe there's some severe drug-drug interactions, I think. So especially if they're a contact or if they have diabetes or something that, might cause them to break down with TB disease.
Yeah, I treat a lot of old people now because I can use rifampin. I did not do that in the old days with INH, but
It's pretty safe.
yeah. The one thing you'd want to do, and I think you may go into it later, but just the drug-drug interactions. I mean, that is something to look at, particularly in older people if they're on other medicines. So that might preclude your ability to use rifampin. So something to keep in mind.
Perfect. Yep. Okay, I'm going to quickly roll through this and give you the answers just because because I realize we have to move along here. So if we had somebody who's a female 42-year-old quantiferin positive and pregnant in the second trimester, I think what we decided we would probably do is maybe defer on the LTBI treatment, but get them a chest x-ray. So that seems good. Or you could treat them with rifampin. It's all, depends on the clinician. A 45-year-old that's quantiferon negative, that is a refugee from Syria, probably nothing much to do. Then we've got the kiddo who's 4, TST positive, 12 millimeters. Kevin, do you think it would be worth it to get an Iger or just go ahead and treat him for LTBI?
Well, obviously you get a chest x-ray.
Chest x-ray, yeah.
And then, I mean, I'd probably get an Iger too. I think you get more information. The more information you gather, it's either going to help you or it's going to not do anything. So I figure might as well get it.
Okay, so moving on to the regimens. So this is a summary of your various LTBI treatment options now. And as we mentioned, there's more than there used to be. So that is really good. When I make a recommendation on treating LTBI, I usually recommend rifampin for 4 months with 600 milligrams daily. I think that most people tolerate it pretty well. It's good for kids of any age, but you do really need to be careful to look for drug interactions. And there's a link to the Curry Center dosing table for kids right there. Another regimen that's quite good is 3HP, which is 12 weekly doses of INH and rifapentine. Directly observed therapy used to be required a long time ago, but it's not anymore. Kevin, you usually like to recommend 3HP, right?
I use it a lot. It also helps get around a lot of drug-drug interactions. I mean, rifapentine has the same interactions, but you're only giving it once a week. So if you're gonna cut into someone's statin levels, you're only going to cut into them for about 36 hours for the whole week. So for a lot of kind of moderate or mild drug-drug interactions, if you use rifapentine, you can not worry about them. Because it doesn't matter if you make their cholesterol pill less effective for a day per week, or there's a number of other drugs I can think of. So it's a good thing. There's some drugs like Eliquis and blood thinners that you can't use with rifampin. You can't even really use with this. I mean, you could, but you might talk to the cardiologist before you do it. But again, it does minimize that drug-drug interaction. So I find it really useful that way. But sometimes you can't get people to get insurance coverage for rifapentine, like Heidi said. So that sometimes precludes its use. So
Yeah, it can definitely be more expensive, the rifapentine. Okay, so to complete 3HP, which is really 12 doses, they need to get at least 11 doses in. And the doses should be at least 72 hours apart and no more than a 4-week interruption in general. Does that seem right? I get
Yep.
questions about this sometimes. It can get kind of confusing for people
Yeah.
when they miss doses.
Yeah, that sounds right. Yeah.
Another good treatment for latent TB infection is isoniazid and rifampin. And so just to make sure you understand, that's rifampin, and that's 3 months daily of isoniazid, 300 milligrams, and rifampin, 600 milligrams daily. And again, that's pretty well tolerated, and almost any kid can take that. Again, you have to look for drug interactions.
Yeah, and I'll just say I sometimes use this too, and I use it in people as a hedge. Like if I'm 98% sure they have latent TB, but there's a little bit of me that worries it's a little bit active, or they have a really low burden active disease, and I'm just not sure. I'll kind of cheat and use this, knowing that would be safer, in terms of not generating resistance, things like that. So it is a good regimen, and it does give you a little more comfort in some situations, perhaps.
Okay, just a couple quick reminders. Don't confuse rifampin with rifapentine. I get calls where this happens still, so don't do it. There's a lot of drug-drug interactions, and it can render hormonal birth control ineffective. So that's an important interaction. Can stain tears, saliva, urine, an orange color. And hepatotoxicity is possible, but less possible than with isoniazid. And then also thrombocytopenia is a possibility. Do you get a CBC before you start these regimens?
I do. I mean, again, you probably don't need to. I mean, cytopenia with rifampin happens, but it usually takes longer than 3 months to happen. I mean, I see it, and it's usually really mild. I mean, I can't think of a case I've stopped Riffin due to cytopenia for more than a decade. So it happens, but it's pretty rare. But some people are pretty anemic to start. I mean, it's kind of good to know where people are at when they start, so.
Okay, INH is no longer preferred, so I'm not going to go through this in too much detail, and we're going to skip this because we're running out of time. Side effects. So in general, patients should stop treatment and call you if they're having any of these side effects here. And if there's any doubt, go ahead and stop treatment for a bit. It's always okay. The person's not going to develop drug resistance if treatment is stopped for a moment, so you can sort things out. That's a question I get a lot. Like if the patient misses doses, are they going to get drug resistance? And the answer is no, as long as they don't have TB disease. And then go ahead and add those doses to the end so you get the right number of doses. So monitoring while in treatment, you want to make sure you see this patient monthly. Try to make sure that they're taking their pills. Look for any symptoms of hepatitis or any other side effects that they might be having. So elevated LFTs, try to figure out what's going on. If they're on INH, consider switching them to RIF.
And
GI
just remember, a
complaints.
lot of people will bump their LFTs. So, I mean, 20% of people will. So you usually just treat through it and it goes back down. But it's important to monitor. If they don't go back down, then, you got to stop drug. So.
Good point. Yeah. Yep. Right, GI complaints are pretty common, so just make sure that you don't have a liver problem happening. Otherwise, you can restart, and then sometimes taking it with food helps or at night, and usually it eventually improves, hopefully. Rashes are also somewhat common. Minor itching, again, you can use some over-the-counter things, antihistamines, and carry on. If it's a particular rash, though, do remember that that could be thrombocytopenia. A peripheral neuropathy is caused by INH, and that's why we usually add vitamin B6. And then finally, completing treatment. So we always have patients who are missing doses. It happens. If they miss a lot of doses, you want to figure out if they really want to commit to treatment right now and what their barriers are. Kevin, if they've missed for like 2 months consecutive, what would you usually do? Would you do a new chest x-ray or?
I mean, probably don't need to do, I don't know. I mean, technically, sure, but I think you have to restart the treatment. So, I mean, you should do a chest X-ray if you're really going to commit to that. So, the 2 month thing is maybe something I came up with, or I don't know who came up with it, state of California. But I mean, there's some rash. There has to be some amount of time where you feel like, well, I'd be more comfortable if I get an X-ray. So I don't know if it's 2 months or 3 months or 4 months, but we often use 2 months as that window.
It's a bit arbitrary, most likely,
Yeah.
yes. Okay, so these are the number of doses the patient needs to complete to have finished the regimen. All right, a few FAQs about LTBI and LTBI treatment. I get a lot of providers trying to report LTBI. It's not reportable in Oregon because the person is not infectious. So in some states it's reportable, but latent TB infection is not reportable in Oregon. And people can certainly refuse LTBI treatment. That is okay. Another thing is, my patient left unexpectedly while they're on treatment. She's been gone for 3 months. What do we do? And we kind of walked through that. Use a shorter regimen maybe if you feel like they could do better on that. The pharmacy didn't have rifapentine. The patient accidentally took INH weekly for a month, which happens as I've gotten that call. What should we do? That's not a valid treatment, so you'd have to restart and maybe want to use a different regimen. Okay, so here's a list of the materials you can access, which will help you learn a little bit more about LTBI if you like. And here are some additional resources for you. And we still have some time for questions. If anybody has questions about latent TB infection or TB disease or anything else, we're here to answer them. Oh, Wendy has her hand raised. Yeah, go ahead.
Sorry, I always have a question. For the quantiferin, if we get an indeterminate result, is it best to just repeat the quantiferin, or if we have access to T-spot, could we do a T-spot? Does it really make a difference? Trying to figure out, is a T-spot potentially more sensitive, or are they about the same?
You know, they're just about the same. I mean, everyone always debates, like, oh, you know, maybe one test is slightly more sensitive, the other one slightly more specific. But I mean, functionally, you know, they're about the same. So I mean, I think you can repeat with either one. A lot of people, if you have access to T-spot, I might be tempted just to do that, but a lot of us don't have access to it, so we just repeat the quantiferin. I think either one's totally appropriate.
Thank you.
Any other TB questions for us? Yay for Wendy, another question.
Sorry, I got one more question. Sorry. So I know the OSPHL went to the 1-tube QFT. Do they divide it up? How does that work, I guess, with compared to the 4-tube? I
Yes,
don't know
they
enough about
divide.
it. Thanks.
Yep, they divided up at OSPHL.
Yeah.
Thank you. No more questions.
Sure.
Any other questions?
All right. Cool, guys.
Yeah. All right. Thank you,
We
everybody.
do have one that Deanne Lang asks if remote historical past positive test med TXP still encouraged. Not, that might be a typo.
So if they were
Is treatment, if maybe is treatment
Yeah.
still encouraged?
Yeah, I mean, if you think it was a real, if you know it was a positive test, I mean, sometimes the patient can give you a pretty good history that, you know, oh, I did the skin test and my arm was as big as a grapefruit, you know, I mean, that kind of thing, you know, was probably positive. So, or if there's written documentation of it, or they can tell you, I mean, you know, if that's the case, they're probably still positive. So, I mean, you definitely could consider treating them, even if it was a remote, you know, it just depends on there are other risk factors and how they might tolerate therapy. But again, as we said, we're kind of treating more and more people given the rifampin short course therapy. So you'd want to examine them, do an x-ray, make sure they don't have any active TB, and then you could think about treating them for latent.
Any other questions before we end our webinar? Okay. Great.
Cool,
Thank you,
guys.
everybody, for joining us.
Thanks. Take it
Bye.
easy. Cheers. Bye-bye.
Thank you.